And what we did in a case like this one, a large block graft, in this case taken from the anterior iliac crest, we can place our implants after 3 to 4 months of healing. We place additional soft tissue for thickness, and we're going to rotate this as a pedicle. We make a releasing incision in the bicuspid area, and we rotate the tissue over the tops of the implant 1/2 tooth over to overlap the interproximal tissues. And that's exactly what you're seeing here. So we don't lose or remove that tissue. We actually enhance it, overlap that interproximal area to gain additional vertical height. We use crown lengthening procedure on the adjacent side to level off the gingival margins, zirconium abutments, and then really trying to get the best aesthetic result. But once again, the limitation when we have two implants next to each other is that you are slightly at a lower level interproximally, and that's just an anatomic consideration that we must appreciate. If we take a look at these cases, what do we do with cases that are losing the teeth due to idiopathic resorption?
And the key over here, of course, is moving along that the first issue is how do we get these teeth out? How do we preserve what remains? Don't do further damage in the process of getting these teeth out. And then the last is which teeth to replace, which teeth to keep. Do they all need to actually come out? And as we're going through this process, really key is to maintain this buccal aspect, as well as obviously the interproximal. This is really considerably more difficult. Utilizing over here the piezo surgery, which really took a bulk of the time in this. And then a decision making, and we're talking about decision making. Which teeth to replace? Where do we put the implants? How many implants do we actually need? What's best for this patient? I'm showing you the different ways we can go about this process. And you can see that over here, as we're taking teeth out, that we're choosing to place the implants. You go through the whole process of staying away from the buccal plate, minimizing the damage to it, and then actually leaving the teeth in between to support that soft tissue. So we're not only preserving the socket, but we're now aiming at developing supercrestal fibers above the socket to maintain that soft tissue. So when we level these roots, the key issue is don't level them with the bone. Actually level it vertical to the bone, developing it in the exact same shape as the underlying or the potential cemento-enamel junction of the new restoration or the existing restoration. And you want to maintain this fiber attachment apparatus that we know about that wraps around the teeth but also inserts into the teeth, maintaining the vertical aspect of the soft tissue. Remember, it's a suspensory ligament for the tooth, but also for that soft tissue around it. And now you can see how we develop the tooth form of the remaining root, the cemento-enamel junction above the bone. When we submerge those vital roots, remember this is not new, this goes back to Jerry Bowers, a member of this academy, really in 1989, vital root submergence. So we didn't actually take away the vitality. We just cut them off in a sterile environment and close them up. And you see cementum growing up over it, and you maintain the soft tissue. Root submergence developing the adjacent now pontics so that we can maintain the aesthetics of the case as best possible. And of course, not compromising the surrounding ridge around it. Choosing your abutments, developing the soft tissue profiles, and then going into your restorative endeavor. And you can see slightly longer, obviously, interfaces at the contact point, but still nice soft tissue profiles, particularly where we've submerged these to support it. And you now have pontic, implant, and whereas we move back, we choose to put more implants where it moves beyond the aesthetic zone. Again, submerged roots, and this is the article Access It on Dental XP. It's there as a PDF, rapidly download.
So you can see the intention was for us to preserve the ridge by simply not extracting the root. And by doing this, we cut the root 1 millimeter above the bone, maintaining the horizontal insertion fibers of the connective tissue, which supports that interdental height and is maximum preservation of the tissue. The conclusion, if you look at the research back in 1978 by O'Neill, actually in the Oral Med Oral Pathology Journal, mentioned that this procedure should be considered as an alternative to extraction of key teeth in an effort to preserve alveolar bone. So this is not something new. It's actually being used in a different way, and this goes back 32 years now. what happens when there are no roots to submerge? In a case like this, where we have only a few teeth left just to support a transitional bridge while we regenerate and add implants, we have a large volumetric type 3 deficiency. We can deal with these in numbers of different ways, and our intent was to show you different modalities. In this case, patient did not want to go through autogenous block grafting. We did not have access to BMP at the time. We utilized allograftic block, and we shaped it over the ridge to support the area between two implants just in the pontic space. And we screwed this in with a bone fixation screw vertically. And this can be pre-fit on a stereolithographic model today. And we placed our implants, and here you can see that bone graft just secured in the vertical and horizontal position, shaped to reconstruct the interdental heights. And we were able to take this patient. We waited approximately 8 months during the temporary phase. And what we've been very, very happy to see on the cases where we can keep the block submerged, we're able to actually engage and enhance that pontic site both in the buccal and vertical component. And here you can see when we finalize the case, very, very nice aesthetics on the 2 platform switched implants. And then, of course, that block now at 1 year after placement is not resorbing. Most importantly, it's supporting the dimensions of the pontic in 3 dimensions. We're publishing this. It's now been submitted for publication. We did 5 cases, a case report, all cases with type 3 vertical defects. There was 1 complication of early exposure and infection. The 4 others were followed up, and now 2 years post-op have maintained the soft tissue height, and the bone has also been shown to stay stable. As we show you these different grafting techniques, and obviously some were quite good in how the result ended up being, but really if we look at the literature, and I look at this from Esposito in 2009 in the European Journal of Oral Implantology, he did a Cochrane systematic review of all the literature related to horizontal and vertical bone grafting procedures. And what he concluded was that there were complications, but that these complications were especially true for vertical augmentation and that they were quite common. So although our best intentions to regrow bone vertically, it appears that that continues to be the challenge for all of us. And that is a challenge for our practice as well. And I started talking to you, and David talked to you about the transition interface, that this is really the aesthetic area, the zone of importance. And we obviously understand that importance. And in some of these very critical type 3 cases, we really had a challenge being able, especially with triangular shaped teeth or highly scalloped gingiva, or patients with high aesthetic expectations, to manage this interface surgically alone. And with that in mind, we started to transition over to another concept, the concept of the pink transition, and whether or not this transition has to occur with surgically created gingiva or prosthetically created gingiva.
So we're now going to show you, we'll be utilizing surgical modalities, how we can handle these different defects within the aesthetic zone. What I want to move now into is to show you yet another option. And it isn't the only option. None of what we've shown you is the only way to go. We're showing you options, but then you're faced with a decision-making process. What to use and where to use it. In any given situation, what do we do best? What do we choose to do? Allografts, xenografts, soft tissue, do we add pink gingiva? Is that the best way to handle it? Is there an answer? So you have options. What can we do surgically? What is predictable? How do we do it? And then should we actually contemplate right from the inception doing it artificially? Should we not even try and do this? And obviously we as a surgical group look at this, trying to bring all of these tools within our armamentarium. So on any given case, just 2 centrals, this is our ongoing dilemma. Do we go ahead and try and augment this tissue, accepting that if we have adjacent implants, where are limitations, not only what we can do surgically, but biologically? How high can we bring this papilla from the underlying bone? And is there a difference when you have implant to implant relationships as opposed to implant to pontic or implant to adjacent root, as you'll see? And then do we actually have the option in any given stage, depending on the patient's limitations as well on when we should actually contemplate doing prosthetics in this. So here you have natural teeth, no change in soft tissue. I'm sorry, implants with restorations, natural teeth, and here we've added soft tissue as an added component. Is one absolutely essential as compared to the other? And the decision-making process involves several things. The first is, what are the patient's expectations? What limitations do the patients impose upon you? The financial, the emotional. How do we look at the timeline? When do they expect it? Then you decide, is it really relevant? This is a smile line analysis. So this is emotional. This is actually a clinical evaluation. Then you look at some of the other issues. How many surgical procedures have they had? How many do they anticipate? And then you look at the actual defect clinically. We kind of focus on the defect and look at that only, but don't look at that only. Look at all the underlying issues that go into the decision-making process determining the final outcome. And then we have to have a way as surgeons to understand the relationship between the defect that we were talking about. Remember, we showed you all sorts of different defects, the modalities we could utilize it, accept some of the limitations that are imposed upon us by the different materials and, of course, just adjacent implants, and then relate it to the actual patient, that individual smile line, that individual lip line. How do we do this most effectively? Because if we don't, as a restorative dentist, or the restorative dentist that you're working with ends up trying to make these teeth fit into the tissue and then integrate it back into the face. You can kind of see the things that I, as a restorative dentist, send a impression back to the laboratory, and I say, make me some teeth. And then, you know, teeth are not all created equally. Look at the difference in form on the same case, actually, between these teeth and these teeth. And how do we facilitate this? And I'm going to introduce Dr. Coachman over here, who's been working with us for really 4 or 5 years, and how this whole process evolved. It's really about tooth form. The pink is about tooth form.
So when we want to move from a situation like this with unattractive aesthetic principles on the left, and you want to move to a more ideal aesthetic situation, the question is, do we want to do it surgically? Do we want to do it prosthetically? Or should we combine both to get to the final result? And we can see definitely that the support of the pink is giving me ideal tooth morphology, and this combination is really changing the patient's face and the patient's smile. So we see the case after 6 years, and I'm really comfortable to talk about this option, this topic with these guys because of 2 main reasons. The first one, they were the first to believe in my ideas and to give me the opportunity to develop this surgical and restorative protocol. And secondly, because I worked with them, and I know that when it comes to surgically reconstruction inside the aesthetic zone, they try them all. Not only try them all, they develop many of the techniques. They created some of these options. They teach these options. And more than anything else, they mastered all these options, and we saw the results together. So when they come to me saying, we need something else, surgically reconstruction by itself, it's not anymore the best option for our patient. So that's when we come into play, and we started to create some options to really fulfill our patients' desires and expectations. And we know that aesthetic expectations nowadays are increasing a lot. So this, I think the main factor is to go through the decision-making process and to try to plan in advance. And the first point is to analyze the case and see if it's a favorable case for artificial pink or not. And to understand that, we really have to know about the interface, as Maurice mentioned, the interface in this case between artificial and natural gingiva. And we have basically 3 interfaces. We have the horizontal and 2 verticals, and we have to see where these interfaces are. Can we manage the ridge to hide these interfaces? How can we play with these interfaces? And we see that this is a favorable case, mainly because the horizontal interface is hidden behind the upper lip, and because the 2 vertical interfaces are actually hidden behind the cuspids. So it's a case that we solved with pink ceramics, and we've been doing pink ceramics for a long time, and it's a perfect case for pink ceramics because the interfaces are not inside the aesthetic zone.